Good afternoon, everybody. The month of May is Lupus and Arthritis Awareness Month. So on behalf of the Arthritis Foundation, Upper Midwest Region, and the Lupus Foundation of Minnesota, I want to thank everyone for joining us today. My name is Cheryl Como, and I'm Vice President of Client Services for the Lupus Foundation. I will be your host for today's webinar, Arthritis and Lupus, Similarities and Differences. Before I introduce our speaker, I want to talk briefly about today's program. The webinar will run up to 1:15 p.m. You will see a dialog box on your screen. Please type your questions in this area throughout the webinar period. Time will be provided after Dr. Ytterberg's presentation for a Q&A. Today's webinar goals include identifying similarities and differences in signs, symptoms, diagnosis, and treatments of both arthritis and lupus. So I'm going to apologize in advance if there are any technical difficulties that occur on my end, but I will make every effort to ensure that this learning opportunity goes uninterrupted. So whether you are new to webinars or a seasoned veteran, here are some tips. On the screen, you will see a telephone number. Please jot it down. This is the go-to webinar support services number in the event that you experience technical difficulties on your end. Their number is 800-263-6371, and the webinar ID is 660-352-390. Audio is through headphones or speakers that are attached or built into your computer. To facilitate sound quality, try to be in a quiet area and adjust your sound as necessary. Presentation slides will be viewed from your computer screen. If you are having technical difficulties again, please contact the support number. Keep in mind that the quality of your connection can interfere with slide transition and sound quality. At the conclusion of the webinar, a satisfaction survey window will pop up. We hope that you take a few moments to complete this survey. And finally, if you require a certificate of attendance, please email me at ccomo@lupusmn.org. So without further delay, I would like to introduce our speaker, Dr. Stephen R. Ytterberg. Dr. Ytterberg is board certified in rheumatology. He is a consultant in the Division of Rheumatology at the Mayo Clinic and is an associate professor of medicine at the Mayo Clinic College of Medicine in Rochester, Minnesota. He received his medical degree from Thomas Jefferson Medical College in Philadelphia, completed a residency in internal medicine at Jefferson University Hospital in Philadelphia, and a fellowship in rheumatology at the University of Michigan, Ann Arbor. Dr. Ytterberg's primary areas of interest and research involve two main areas, vasculitis and inflammatory myositis, which includes polymyositis, dermatomyositis, and inclusion body myositis. He is a member of the Medical Advisory Board of the Myositis Association and served as a member of the Subspecialty Board on Rheumatology for the American Board of Internal Medicine. He is also the past chairman of the board of the Arthritis Foundation, Upper Midwest Region. Thank you for joining us today, Dr. Ytterberg. The floor is yours.
Well, thank you, Cheryl. It's a pleasure to get to do this. And what I've put together is, to my mind, sort of a whirlwind of trying to cover a lot of material in a short amount of time. So I was asked to talk about arthritis and lupus. And what I've done is actually to focus the arthritis part on rheumatoid arthritis rather than talk about other kinds of arthritis. In advance, I will apologize if some of the slides are too complicated. This comes from a talk that I put together for physicians, and I've edited it to try to get it into more lay mode, but I may have missed some things. I will try to pick it up as we go through the slides and clarify whatever seems unclear. So what I plan to discuss today is mostly about rheumatoid arthritis and lupus, but I'm going to start with a short discussion about assessment of disease activity because this is a very important aspect when thinking of any disease that's being treated, knowing how do we know if patients get better. So assessing disease activity. And as I said, how do I know if my patient's improving? Well, there are a few areas of data to use. One is to think of things that come directly from the patient, so patient-reported data. And this can come from the history, just with talking with the patient. Is there more joint swelling? Is there more pain, etc.? Many are trying to now use structured tools, so there's some similarity to the data from visit to visit. And I'm going to talk about a few of those as we go through this. The second part are features that come from the physical examination. Are there swollen joints? Is there a new rash in somebody with lupus? Is the rash that had been there gone away now? So there are features from the clinical exam. And the third area is to use testing, and this goes under the general terminology of biomarkers. So these are markers that we hope indicate something about how active the patient's disease is. And this might be a laboratory test, could be a chest x-ray or some other imaging study to say, has that pneumonia gotten better? Or are there changes in the hand x-rays in a patient with rheumatoid arthritis? And finally are some functional assessments. These are generally tools that, there's two varieties. Some are tools that patients fill out as questionnaires, but some might be asking the patient to do an activity such as a 6-minute walk time. So a number of things that go into assessing activity. Now, when doing clinical trials or studies of new drugs, the question always is, what's the outcome measure, or what's the trial endpoint? And people who study these things talk about 3 levels of data. One is a clinical endpoint, which is usually a very hard outcome. That is, there's little ambiguity about it. A surrogate endpoint is something that we think may predict that final endpoint. And then again are these biomarkers, something that's easy to measure that we hope predicts outcome. So I'll show you that in this slide. So this comes from a publication from nephrologists, and this group does a lot of things related to lupus and vasculitis. But thinking of a clinical endpoint is something such as the patient dying. It's very cut and dry. Or from the standpoint of nephrology and renal disease, has the patient had to go on dialysis? Are they in end-stage renal disease and now needing dialysis? A surrogate endpoint might be something like an increase in the creatinine level, which measures kidney function. Biomarkers, something like an increase in protein excretion in the urine, the sedimentation rate. These ANCA tests are antibody tests that go with some kinds of vasculitis. So it's trying to say, where is the hard data about what the outcome is and how the patient's doing? Now, I'm always quick to discuss this with our trainees and also with patients, is the concept that just because there is a symptom present doesn't mean that the disease is active. So not all symptoms are due to active disease, and it can be that, for instance, with rheumatoid arthritis, a joint has been damaged by previous inflammation and there's still pain in it, but there's not ongoing rheumatoid inflammation that calls for more aggressive medical treatment. Similarly, in a patient with lupus, if there's been kidney inflammation, it can damage how the kidney works. And ongoing poor renal function doesn't mean that there's ongoing activity involving the kidney. So it's always important to try to identify whether the symptom or the problem or whatever seems wrong is from disease activity, which requires more treatment, or is it damage from the previous activity. Now, just to complicate this a bit more, sometimes the symptoms are from drug side effects. It's not unusual for me to see somebody, say with lupus, who ends up being treated with large doses of prednisone, come back and tell me that they're no better, when actually what you see is that what had been treated initially, say arthritis and rash, has improved, but by the no better they mean that they feel crummy because of the weight gain from the prednisone, because of the moodiness, because of the poor sleep, etc. So always trying to figure out, are symptoms from active disease, damage that's come from previous disease, or is this a medication side effect? Now, There's a lot of interest in patient-reported outcomes, and this is the website from the NIH and their PROMISE program, which is focusing on patient-reported outcome measures. And there's a lot of push from the NIH for people doing studies to include patient-reported outcomes as part of the assessment. And we'll talk some about this as we talk about rheumatoid arthritis and lupus and assessing management. So with that brief introduction to talk some about outcome measures and assessment of disease activity, let me start first to talk about rheumatoid arthritis and then go on to lupus. So we'll begin with the case. So this is a 42-year-old woman who's had 3 weeks of pain, swelling, and stiffness in her hands, wrists, and ankles. Her symptoms are worse in the mornings when she gets up, and they improve somewhat by midday. She's been using over-the-counter ibuprofen, and it takes the edge off, but no more. On examination, she has swelling and tenderness of small joints in her hands, her wrists, and her ankles. And laboratory studies show that she's anemic. She has elevation of inflammation markers in the blood, the sedimentation rate, or erythrocyte sedimentation rate, and C-reactive protein. Other assays for antibodies associated with rheumatoid arthritis, including rheumatoid factor and CCP antibodies, as well as the ANA, a screening test for lupus, are all negative. So 3 weeks of pain and swelling in multiple joints. And the question is this rheumatoid arthritis? We'll talk some about that. So characteristics of rheumatoid arthritis is a systemic, chronic, inflammatory condition. It mainly affects the synovial joints. These are the major joints that let you move around: shoulders, elbows, wrists, fingers, etc. So there's a female predominance in the disease, so about 3/4 of people with rheumatoid arthritis are women. It tends to affect younger people, although it can occur at any age. The peak age of onset is between 25 and 50 years old. It's seen worldwide, and it's estimated to affect about 1% of the population. And often shows up with swelling, typically small joints in the hands. This whole hand looks swollen. Again, it looks like there's some swelling across these knuckles and there are these characteristic nodules that have formed in this patient. These are called subcutaneous nodules. The most common place to see them is at the elbows. And with ongoing active inflammation, there can eventually be damage. And this is the idea that this person has lost function in their hands because of the damage that's occurred to the joints, but there may not be active inflammation yet that requires ongoing treatment. So this slide is a bit complex, but it gets to the point that rheumatoid arthritis is a systemic condition. We think of it primarily as a joint problem, and it is primarily a joint problem, but it can target other organs, and there can be inflammation in many other organs. So it can affect the eye and cause inflammation of the sclera, called scleritis, can cause dryness of the eyes. In the lung, there can be inflammation of the pleura, the lining around the lung, and that can cause fluid to form in that sac. There can also be nodules that occur within the lung itself, and sometimes even scarring in the lung. It can cause lymph nodes to enlarge. This is trying to point to some lymph nodes in the armpit. It can cause inflammation around the heart, called pericarditis, and again, fluid can accumulate and impair heart function. It can cause a condition called amyloidosis, with accumulation of abnormal proteins, which can cause problems in the gut or in the kidney. The spleen is sometimes enlarged. It can cause inflammation in the kidney on rare occasions. It often causes anemia, and with active inflammation, the platelet count can go up. In the past, without good treatments for rheumatoid arthritis, it was not unusual to see patients who were wasting away just because of the ongoing inflammation in their body. It would be muscle wasting. Occasionally there's inflammation in the muscle. The skin can be affected with thinning of the skin and ulcers, and nerves can be affected, causing neuropathy or mononeuritis multiplex, which can cause things like foot drop. So it has the potential to affect many organs, and we have to be on the lookout for things other than joints. The final bit is that there have been studies that have shown an increased risk of coronary artery disease in patients with rheumatoid arthritis, and this has also been extended to patients with lupus as well. It seems there's something about chronic inflammation that leads to acceleration of heart disease. So, of patients who have rheumatoid arthritis, what do they die of? And the overwhelming, or the number one cause of death is from cardiovascular disease. Now, this shouldn't be a surprise because it's also true in patients who don't have rheumatoid arthritis. It's followed by cancer, infections, kidney disease, lung disease. Death being attributed to rheumatoid arthritis itself is relatively uncommon among all these. GI problems, central nervous system problems, and accidents. Now I want to talk a little bit about some of the laboratory testing for rheumatoid arthritis. This often gets focused on, and indeed it's almost like job security for us. Patients are tested because of symptoms, abnormal antibodies are found, and lo and behold, they're sent to us for an evaluation. So in rheumatoid arthritis, there are two antibodies that are found in the blood that seem to correlate with the disease. The oldest one was called rheumatoid factor, and the newer one, really just studied in or used widely in the last 10 years, is called anti-cyclic citrullonated peptide, or CCP antibodies for short. So rheumatoid factor, sensitivity means how many patients with rheumatoid arthritis have this antibody. And at best, it's only 70 to 80%, and when you look at patients at the time of diagnosis, it's only about 50% more or less. Now, the specificity is low. That means that the antibody or the test can be positive in people who do not have rheumatoid arthritis. So as a screening test, it's difficult. The presence of this antibody tends to be associated with severe disease, with patients who have nodules and erosions in bone. And all of us can make rheumatoid factor. Making this is probably a normal part of the immune response, but gets to be more prominent in patients with rheumatoid arthritis. Now, these CCP antibodies have a sensitivity of about 40 to 60%, so not as many patients have them, but if a patient has them, it's a pretty safe bet that they have rheumatoid arthritis. It's not 100%, but it's more than with the rheumatoid factor test. Again, patients who have CCP antibodies tend to have more aggressive disease, and the usual thinking is that they need to be treated more aggressively. This slide just makes the point that even before the onset of symptoms, so here would be the onset of symptoms at time 0, and going back 1, 2, 3, even 10 years before the onset, patients start to have positive tests for some of these antibodies. And it raises the question of whether early intervention would be meaningful. It also gets to that issue that I just mentioned on the last slide about the low specificity of the test. Oh, let's see if it'll advance this way. Okay. Just check my notes, and this is actually the next slide. So to make the diagnosis of rheumatoid arthritis, people who study rheumatoid arthritis struggled with this, of saying how can we all agree if we're going to do a study of a new medication whether the patient actually had the disease. And this was the original set of classification criteria, and we always point out that these are not put together to make a diagnosis, but they help us think about the disease. So it's hearing morning stiffness for more than an hour. This has to be present for at least 6 weeks. If you remember the case I presented, it only had symptoms for 3 weeks. Swelling in at least 3 joint areas, which she had, and specifically having swelling in small joints of the hands, that's one that I didn't correct, or the wrist joints, and having symmetry to it. The presence of those rheumatoid nodules, a positive rheumatoid factor, and these criteria were put together before the CCP antibody was found, or typical changes on the x-rays. And so it was felt that if patients had 4 of these criteria, they probably really have rheumatoid arthritis. Now these were updated just a couple of years ago, and in this new version you'd need at least 1 joint with definite swelling and not having a better explanation for that swelling. Now to get to the diagnosis of rheumatoid arthritis takes 6 points, and you can get up to 5 points because of the joint trouble. So if there are more than 10 joints, with at least one of them being a small joint, gets you 5 points. And you see the emphasis, a large joint doesn't count, a whole bunch of large joints doesn't count, but even just a single small joint gets you more points. So it's that small joint predominance of this disease. And then there can be points for the rheumatoid factor or CCP, mildly positive or strongly positive, those inflammation markers being present. And again, you see the 6-week rule comes in here, that you get a point if inflammation's been there for 6 weeks. So this patient had elevated C-reactive protein and sedimentation rate, had more than 10 joints affected, so would meet the criteria even though she's only had disease for 3 weeks. I'm going to spend a little bit of time talking about what happens in rheumatoid arthritis. Here I've got a cartoon of a joint, and here a histologic section, so a microscopic section looking at a joint. So this was set up to be a knee. Here's bone, bone, cartilage, cartilage, and this would be the meniscus in between. The point I want to make is that the cartilage gets its nutrition from these cells called synovial cells, or the synoviocytes, or it's the synovial membrane, which lines the inner part of the joint capsule. And it's usually a very fine, delicate tissue, and its function is to provide, or to make joint fluid, which provides the nutrients for the cartilage, because there aren't blood vessels that come to the cartilage. And looking under the microscope, here's bone, here's the other bone. This is the cartilage that lets the bone move smoothly against each other. The synovium is just the faint tissue inside of the joint capsule. Now, in rheumatoid arthritis, what happens is that synovium grows and grows and grows. So here it is in the cartoon, that faint and fine tissues thickened, and it's aggressive, it's inflamed, it's got immune cells, it's got inflammation cells, and it can actually erode its way. This is a higher power view than this, but here is the cartilage, and this tissue, this synovial tissue called pannus, is eating its way into the cartilage and into the bone. And this just the reminder that there are immune type cells. The synovium grows. To support it, it needs new blood vessels. It can eat its way into the cartilage and bone, and there are other inflammatory cells. What does this do? Well, it causes damage. Here's an MRI image of a normal wrist. So we see these bones with nice space between them. It's all nice and symmetric. Here's a wrist from a patient with rheumatoid arthritis. And what you see is all this fuzzy gray stuff in here. And this is the synovium. This is that pannus tissue, the overgrown synovial tissue that should be fine. And what it's done is to cause erosions. So the bone doesn't look nice and smooth like it did in the normal, but this synovial tissue, the pannus, is eating its way into the bone and causing erosions. And that's what we want to stop. Okay, so here's an X-ray of a hand rather than an MRI, and again you can see these erosions that have come from the disease. And at the end can cause deformity. So we'll talk some about treatment approaches to rheumatoid arthritis. Now, this is something that I don't think you'll find in textbooks, but this is my sort of how I construct this of what happens with these autoimmune inflammatory conditions. And I draw this for my patients with rheumatoid arthritis. I draw it for my patients with lupus. I draw it for my patients with vasculitis, because it's the same concept, and that is that inflammation causes trouble. If I can get this to click again. So inflammation causes the symptoms, and you can treat the symptoms with analgesics. If this is arthritis, if it's inflammation in the joint, causes joint pain, painkillers. But using an anti-inflammatory drug to quiet the inflammation, such as ibuprofen, naproxen, celecoxib, etc., or to use prednisone, to use steroids, can quiet the inflammation and limit the symptoms. The thing about this, though, is that the inflammation is being caused by this autoimmune disease. So the immune system's usually a good guy, fighting off viruses and bacteria trying to get into the body, but there are a number of conditions where the immune system gets turned around and starts to attack the body itself, and we call these autoimmune conditions or autoimmune diseases. Rheumatoid arthritis and lupus are classic autoimmune diseases. So it's the autoimmune disease that drives the inflammation that then causes the symptoms. And the logic is to treat as far upstream as possible. So the approach is optimally to quiet down this autoimmune disease. So we use drugs that mostly target the immune system. And these are called disease-modifying anti-rheumatic drugs, or DMARDs, in rheumatoid arthritis. But if we treat with something from this column and there's ongoing inflammation, we can treat that with steroids or non-steroidals. But the idea is treat as far upstream as possible, and then you can hopefully get by with less treatment here. So, of these DMARDs, the ones that were around when I started my training, we won't talk about how many years ago, were injectable gold compounds. I've not given these to patients in probably 15 to 20 years, I bet. So we used injections of gold. There was an oral gold compound, and we used penicillamine. All of these do things to the immune system, but in a very non-specific way. More recently, we've had other DMARDs that I call non-biologic DMARDs, and this is obviously going to be in distinction to biologic ones, which we'll talk about next. So plaquenil or hydroxychloroquine, sulfasalazine, methotrexate is the key for most of our treatment of rheumatoid arthritis. We'll sometimes use a drug called leflunomide, sometimes azathioprine. All of these drugs do things to the immune system in a non-specific manner. More recently, we've used these drugs that are termed biologic disease-modifying drugs. There's a family of TNF inhibitors. So TNF is one of the signals in the immune system, and we now have 5 different drugs that target TNF. There are drugs that target other parts of the immune system. Let me show that, I think, in the next series of slides. So the concept is that in rheumatoid arthritis, these cells of the immune system called T cells or T lymphocytes are stimulated by antigen-presenting cells from the immune system. They have to recognize signals that then stimulate the T cell, and through the immune stimulation, a whole host of chemicals are released that then do other things in the body to these synovial cells, to the cartilage. And the direction lately has been to treat this by directly targeting parts of the of this cascade. So these TNF inhibitors target TNF alpha. And this is hanging up for me again. We'll keep trying to click. Oops, now I went one too far. And as I said, there are 5 of these on the market now that are given subcutaneously or intravenously. There's a drug that targets this interleukin-1 called anakinra, one that targets interleukin-6, tocilizumab, one that targets this interaction of the T cells and the antigen-presenting cell, abatacept, one that targets B cells, in this cascade, rituximab. So I'll have a summary about this a few slides on, but the concept is back to where I started of assessing disease activity. The American College of Rheumatology, our professional organization, put together a series of criteria for assessing response to drug called the ACR 20, 50, and 70 response. The European people studying rheumatoid arthritis have used this score called the DAS score, and others have come up with these other disease activity scores. Let me talk just a bit about the ACR 20. One of the problems with the ACR 20 is that it takes, you don't get very much improvement. So to say you met this criteria, you need a 20% improvement of the number of tender joints, 20% improvement of the number of swollen joints. Well, if you've got all of the knuckles in your hand inflamed, which gets to 20 joints, a 20% improvement means you're down to 16. And I don't think that that's functionally very much. That's why they subsequently came up with the ACR 50 and ACR 70. So in addition to this, patients would need to have 20% improvement in at least 3 of the following. And I use this just to show the type of data that go into this assessment. So it's the patient-derived data, the patient's pain, the patient's overall assessment of how they're doing, the physician's overall assessment. This HAC score is a questionnaire widely used in rheumatology practices, and then the inflammation markers in the blood. So this slide gives some sense of what it is that's being measured. And I think the goal now for most rheumatologists is to use at least one of these outcome measures to try to assess if patients are improving or not. And I'll show you why in just a minute. But they tend to use the same type of data. So the number of tender joints as you squeeze them, the number of joints that are swollen, the amount of pain reported by the patient, only used for this one. The patient's overall assessment is an important component of assessing improvement. The physician's overall assessment, this HAC score, and then the inflammation markers. So why this is going to be important, there have been a number of studies now that are trying to look at tight control of rheumatoid arthritis. And I discuss this as being similar to how hypertension doctors approach treating hypertension. There's a goal. You want to get the blood pressure down to a goal. If it's not there, you do something else. And the same approach is now being considered in rheumatoid arthritis, to say that you have a goal to try to get this DAS score. In this particular study, they used this score called the DAS to below 2.4. And if patient wasn't there, you do something different. You add a new drug, you increase the dose of the drug. So this just shows how if you do that, obviously you're trying to get this lower, it goes lower. People often measure the sedimentation rate, C-reactive protein. These will tend to change with disease activity as biomarkers, but aren't very good biomarkers. What is important to note, though, is that rheumatoid factor and the CCP antibodies don't change with disease activity. So just to summarize, rheumatoid arthritis, so I'm running late, aren't I? Immune-mediated inflammatory disease. We're trying to understand the mechanisms. There are new therapies, and what's being used more as a targeted approach to therapy. And having good measures and good biomarkers is important. So lupus. So here's a case to start, a 32-year-old woman with rash and joint pain. Her symptoms came on after a period of prolonged sun exposure a month earlier. She has rash on sun-exposed areas of her face, upper chest, arms, and legs, and she has arthritis in multiple joints. Her work shows a low white blood cell count, and specifically the subset of white cells called lymphocytes is low. Her urine sample's normal. She has a positive ANA, the screening test for lupus, and I'll talk about that later. She has other lupus-related antibodies, one's toward double-stranded DNA, and her ENA, extractable nuclear antigen antibody panel, shows antibodies toward this thing called SSA or Rho, and complement values in her blood are decreased. So why is this lupus? Well, she has a lot of typical features. She has rash that came on from sun exposure, arthritis, low white blood cell count, specifically low lymphocytes. She has the appropriate antibodies, and complement is low. A fairly classic picture for lupus. So what is lupus? I describe lupus as a multi-system, so it can affect multiple parts of the body, immunologically mediated. Again, it's the immune system. It's autoimmune that's driving the inflammation. And it is inflammation. We don't know the cause. It typically affects young women, and it's characterized by the presence of antibodies directed toward the patient themselves. So the clinical manifestations of lupus are multiple. Again, this is another thing that helps keep us in business, because patients with all kinds of symptoms at some point might be queried as whether they might have lupus. So it can cause constitutional symptoms, fever, fatigue, weight loss, Raynaud's phenomenon, fingers turning blue and purple when they're cold. A number of skin conditions. So here would be a typical looking lupus rash on the cheeks. It spares this nasolabial fold. She's got some on her chin as well. Here's a discoid lupus rash. It happens to be on the face, but it's sort of scarred and atrophic in the middle, and the active edge is out on the periphery of it. Here is lesions that are called subacute cutaneous lupus. It looks like the discoid lesion, but not quite as aggressive. And here are vasculitic lesions, so inflammation that's involving the blood vessels, causing these reddish blotches. So it can also cause arthritis, kidney problems, low blood counts, white blood cells I talked about, platelets, red blood cells. It can cause pericarditis, as rheumatoid arthritis can, inflammation around the heart, inflammation around the lungs. There can be involvement in the lung itself, and finally involvement of the central nervous system. So multiple manifestations of lupus. This chart gives some indication of the frequency of each of these. So in green would be the frequency at the onset of disease, and in blue at any time over the course of disease. So constitutional symptoms in 2/3 or more, arthritis or joint, so swelling is arthritis, joint pain is arthralgia, skin involvement in more than half, mouth sores, nasal sores, pleurisy, pericarditis, Raynaud's, kidney disease in approximately half eventually, central nervous system and muscle inflammation. So as with rheumatoid arthritis, people studying lupus had the problem of trying to decide what are we going to call lupus if we're going to do a study. And this is even more of a problem for lupus than it is for rheumatoid arthritis. I'm always quick to point out what I've circled here, and that is that these were put together as classification criteria. These are meant for doing studies, so that if I say I've studied 50 patients with lupus and treated them with treatment X, they met these criteria, virtually everybody would agree that my patients, maybe not all of them, but the vast majority really had lupus. We sometimes use these to help think about diagnosis, but these are really for studies and classification. But they're very helpful for thinking about what it takes to make a diagnosis of lupus. So there are a number of skin features, the malar rash and the discoid rash, having rashes that come on from sun exposure, having mouth sores. And then there's arthritis, serositis, which includes both inflammation around the heart, which is pericarditis, or around the lungs, pleuritis or pleurisy, kidney involvement, nervous system involvement, dropping blood counts, then a positive ANA, and this thing that vaguely says immunologic disorder really means having some other autoantibody in addition to the ANA. So let me just talk a few minutes about the autoantibodies. So these anti-nuclear antibodies, this means that patients who have these have antibodies in their blood. So we make antibodies to protect us from influenza. When you get a flu shot, you're making antibodies to influenza. Well, patients with lupus have antibodies that are directed towards things in the nuclei of cells. And there are a lot of things in there. And different patients can have antibodies that target different things in the nuclei. Important ones are antibodies to DNA, especially toward the natural form of DNA, native form, which is double-stranded DNA. Sometimes there will be antibodies towards single-stranded DNA as well, but the important ones are the double-stranded DNA antibodies. And then the other important one is the group of antibodies toward what's called saline extractable nuclear antigens, or the ENA antibodies. And I'll show you some of these on the next slide. The ANA is highly sensitive for lupus. Virtually everybody with lupus has a positive ANA, and indeed it's hard to make the diagnosis if this test is negative. But it's not specific. Again, a lot of other things can cause the ANA to turn positive other than lupus. And one has to be aware that there are different assay techniques, and it's hard to compare an ANA test done with one technique with one done with a different technique. So here's the list that I use for my talks with our residents and fellows of causes of a positive ANA. So in addition to lupus, there are related conditions such as Sjogren's syndrome, scleroderma, polymyositis, and many of these patients will have a positive ANA. I view them as cousins of lupus, basically. Then patients with other autoimmune disease. We don't have the market cornered on autoimmune conditions, but there are autoimmune thyroid diseases, autoimmune gut diseases, and some patients with other autoimmune conditions can get a positive ANA. There are some medications that can turn the ANA positive, and some infections that can make the test positive. Sometimes it's positive in patients who have cancer. Sometimes it just seems to be there in older patients. If you look at older patients, there are probably more false positives than there are in younger people. And sometimes we have no clue. So sometimes it's just there. Now, this gets to the idea of some of those other more specific antibodies. So after the ANA is positive, we go looking for antibodies toward double-stranded DNA, and these occur in about 40 to 50% of patients with lupus, but if they're there, it's a pretty good bet that the patient has lupus. The same with these antibodies toward SM, which stands for Smith, SSA or Rho, and these can occur in Sjogren's syndrome, which is where the SS comes from, Sjogren's syndrome A and Sjogren's syndrome B, and then these RNP antibodies. Okay, keep trying here. Now, one of the, a very interesting study that was published, see it's now 9 years ago, was this, and it's given me some concern because what this shows is in these colored lines is the percent of patients with positive autoantibody tests. So the green one's the ANA, the blue one was that row, yellow's the DNA antibodies. And what this shows is 1, 2, 3, even 5 years before the diagnosis, or on the right, even that long before the first manifestation, the first symptom of lupus, patients have positive autoantibodies. And that's given me some pause in patients who are referred to me because of a positive ANA test, but we don't see anything specific for lupus. Because it is possible that that patient, if followed long enough, is actually going to develop lupus. So I now caution people to or talk some about the symptoms and to what kind of things to look out for. Now, in lupus, the autoantibodies cause disease. We don't know that that's true of rheumatoid factor and rheumatoid arthritis or those CCP antibodies. But in lupus, the antibodies that are present cause disease. So some patients, in addition to the ANA, have other autoantibodies, self-directed antibodies. There are antibodies directed toward red blood cells that can cause anemia. The low lymphocyte count usually comes because there are antibodies that are targeting the lymphocytes. Some patients have antibodies that are targeting platelets, and they develop thrombocytopenia. For patients with arthritis and patients with kidney involvement, it's usually that those DNA antibodies are recognizing DNA and form complexes of material that then get filtered out in the kidney and cause the kidney damage. So it's the antibodies that are really causing the trouble in lupus. Now, when I follow patients with lupus, I typically follow the level of DNA antibodies because these tend to correlate with disease activity. That is, the amount of the antibody is usually low when the disease is inactive and tends to go up when the disease becomes active. Similarly, I follow complement values because these are parts, these are compounds that are used up in the immune system, and when the immune system is overactive in lupus, the amount of complement in the blood tends to go down. So again, back to the idea of biomarkers, these are pretty good biomarkers for disease activity. But having said that, I don't change treatment based simply on the level of these. The treatment decisions are really based on what's happening to the patient. Now, just very briefly, this was the first research project I ever did as a fellow. We looked at patients with lupus and looked in their blood and were able to measure interferon. So interferon is one of the signals in the immune system. And we did this before some of the more current classification symptoms are out, and this was one that we made up ourselves. There was definite severe, definite moderate, definite mild, or possibly active. It seemed that the amount of interferon correlated. Now, this has been looked at in newer studies, and I included this one because this Emily was funded by the Lupus Foundation for some of her work. She's at the University of Minnesota, and they now have developed what they call an interferon signature. So they measure the genes, which genes related to interferon production are turned on at any time in the body, and basically can show that, and they then score this. And if you have a higher score, that tends, so here's the interferon score, tends to correlate with the number of lupus criteria that are present, tends to correlate with the presence of more active disease as well. So, management of lupus. You've seen this before because, as I said, it's sort of how I approach these conditions. Now, we might put different medications in different orders, but it's the same concept. So if a patient with lupus has Raynaud's phenomenon, in fact, that doesn't respond much to steroids, nonsteroidals, or immune-suppressing drugs, but will use vasodilating medications. Most components of lupus are pretty well controlled, pretty well treated with steroids. The problem is the side effects. And so, again, the issue is to treat with something further upstream, something to quiet the immune system. Nowadays, it's almost gotten to be a knee-jerk reaction to think that patients with lupus should be treated with hydroxychloroquine unless there's some contraindication to it. This slide gives the idea of what's happened to treatment of lupus over decades. So steroids were first introduced for treating, prednisone, I should say, were first introduced for treating inflammatory conditions in the late 40s. The Nobel Prize for it was given to our first chair of rheumatology, and that was awarded in 1950. So here, looking at studies from the pre-steroid era, it's pretty miserable survival. 50% of patients made it 4 years, basically. With the introduction of steroids, things improved, and with the introduction of immunosuppressives, things improved as well. Now, I've got to point out this isn't all the drug treatment, but some of it is recognizing disease. Back here, it was probably only patients with severe forms of lupus that were probably life-threatening to begin with who were recognized. The test that led to the finding of the ANA test was first described in 1948. So we didn't have good testing, good ways to identify lupus back here either. So I draw this for my patients with lupus, and it's the idea that not all lupus is the same and not all patients with lupus need the same kinds of treatment. So I look at what's going on with the patient with lupus. I look at on the right-hand side as patients having more severe disease, although we recognize that there are worse and milder forms of lupus nephritis. But in general, kidney involvement, central nervous system involvement tends to be worse. Dropping blood counts, inflammation around the heart and lungs, sort of in the middle, rashes, arthritis, etc., on the not-so-bad end. Having said that, I've seen patients with terrible rashes that need very aggressive treatment. So then it's to tailor the treatment. Down here it might just be non-steroidals, the Plaquenil, hydroxychloroquine, maybe steroids, maybe the vasodilator for Raynaud's. In here we're probably talking steroids and an immune-suppressing drug, and over here probably more higher doses of prednisone and maybe a more potent immune-suppressing drug. So showing it a different way, thinking the constitutional symptoms, musculoskeletal, serositis, inflammation around the heart or lungs, skin disease, major organ. And so non-steroidals can help with some of this, not major organ disease. Steroids can actually help quiet the inflammation in any of these areas. It's a question of whether it's on the skin, low dose or high dose prednisone. But to get around the prednisone side effects, then we think of using hydroxychloroquine as an anti-malarial agent, methotrexate, azathioprine, mycophenolate as immune-suppressing drugs, or cyclophosphamide as the big gun, basically. As with rheumatoid arthritis, the wave of the future is to think of targeted therapy, to say if we can better understand what's going on in the immune system, we can better target the treatment and hopefully have fewer side effects. So of cells in the immune system, I talked some about T cells in rheumatoid arthritis, and some people are looking at some of the drugs used to target T cells. This abatacept's approved for use in rheumatoid arthritis. B cells, another component of the immune system, also play a role. Surprisingly, this drug rituximab, which is very effective, it actually just wipes out the B cells and is approved for treating rheumatoid arthritis and vasculitis, theoretically should work in lupus, but the studies that have looked at it have not been successful. This also targets the B cells and is not approved. This anti-Bliss molecule called belimumab, or Benlysta is the trade name, also works to regulate the B cells. It, as compared to the rituximab, did work in the trial and actually has FDA approval and sort of the recognition of being the first drug approved by the FDA for lupus in decades. As with those other chemicals, people are looking at drugs that target the TNF molecules, interleukin-10, interleukin-6, and as I talked about the interferon, there's interest in developing products that will interfere with this interferon signal. So with assessing a patient with lupus, I always try to think, how active is the disease? How much damage is there? Is there increasing amounts of damage? Whether it's scarring from skin rashes or worsening of renal function. To be on the lookout for comorbid conditions, infection, osteoporosis. Just as in rheumatoid arthritis, it's now been found that there's an increased risk of coronary artery disease, and we worry about young women developing coronary artery disease because it is young women who get this, who get lupus. I worry about drug side effects and issues related to quality of life. So the last few slides here. As in rheumatoid arthritis, different groups are looking at different activity measures. A commonly used one for drug studies is called the BILAG, which obviously originated in Britain. It's unfortunately very cumbersome to use. The Europeans have another one that they've developed. The SLEDI is one that's been used in a number of studies in the United States, SLAM another. As you can see, these are all fairly old activity tools. So when following a patient with lupus, I think it's important to follow the complete blood count to see that the blood counts aren't dropping, a creatinine because that looks at how the kidneys are functioning, a urinalysis to know if there are indicators of inflammation in the kidney, these inflammation markers, complement levels, as I showed you, can drop when the disease is active, the DNA tests, and then other things that are specific for the drug that the patient's taking. If they're on methotrexate, we'll want to look at liver tests, for instance. So to summarize, just over 1 o'clock, so we'll leave about 15 minutes, or not quite 15 minutes, for questions. My two summary slides. The causes of rheumatoid arthritis and lupus remain elusive, but the mechanisms underlying them are being better understood. The criteria, as I showed you on the slides, for rheumatoid arthritis and lupus are meant for classifying patients for research studies, but can be helpful in thinking about diagnosing patients. Activity scores are increasingly being used as goals for therapy in rheumatoid arthritis. The activity scores for lupus are more of a problem because of the widespread manifestations of lupus. The treatments for both rheumatoid arthritis and lupus, treatment is moving from non-specific therapy directed toward inflammation and the immune system in general to more targeted therapy as we better understand the mechanisms of disease. And the search continues for better laboratory biomarkers to try to assess disease activity. And with that, I am done and will be happy to take questions.
Okay, thank you, Dr. Ytterberg. We do have some questions here, and let me get to the first one. Oh, okay. Okay, are the environmental causes are there environmental causes or corollaries? What lifestyle choices can reduce the potential onset of arthritis or lupus?
Okay, so environmental causes. The second part was what lifestyle changes.
Yes.
So, excellent questions. We don't know what causes these. For most autoimmune conditions, the theory that most physicians have, most people studying these, is that it's probably a two-step at least two steps that are involved. There are clearly some genetic relationships. People doing genetic studies show that there are some genes that seem to correlate with development of autoimmune disorders. Saying that there are genetic things doesn't mean that the diseases are directly inherited. It's more that you inherit genes that probably put you at risk for developing an autoimmune condition. Then something has to occur to trigger it. And we basically don't know what that trigger is. People have often thought that it's something in the environment and that it might be an infection, but searches have not been very useful. In lupus, however, we do know that sun exposure can trigger flares in some patients, and there is some theory that it might be that sun exposure damages skin, and it specifically damages some of the nuclei of the cells that then lets the DNA be released, and somehow the immune system sees the DNA that's been damaged. It's totally not clear, but that is one trigger that is known. Lifestyle changes. I don't know that there are things that we can do that can prevent development of these diseases. People ask me about diet. Studies that have been done haven't shown anything in the diet of patients with lupus or rheumatoid arthritis that seems to be a trigger, nor is there anything missing. My mind just went blank. I had two more things. I was going to talk about lifestyle, but there are ongoing studies with several autoimmune diseases. There's been question of environmental exposure that might be through the lungs as well. A number of these conditions can have lung inflammation as part of them. And so that's been yet another theory.
Okay, we have another question. Do you have any advice for patients regarding effective communication of their pain levels, so their physicians have a better understanding? You know, oftentimes we think of the assessment tool for pain. Do you have any suggestions?
So, I think using terms that the doctor understands, I don't find it helpful. So in many clinics now, patients will be asked to rate their pain on a scale of 0 to 10. In our practice, we have, as the patient fills out the piece of paper that has that HAC score on it, at the bottom of the sheet is a line that has, it's measured at 100 millimeters, so we can measure it easily, and patients are asked to make a mark on the line to indicate their level of pain. So that's a very standardized tool. Others might have little bubbles to fill in. But in a lot of clinics, it's the nurse asking, on a scale of 0 to 10, how do you rate your pain? So giving some clue that way. What I find unhelpful is somebody saying it's a 12. I mean, use the scale as it is. And yes, if it's 10, if it's very severe, that's a 10. But I think doing something, if you're not asked, it might be worthwhile just saying, gee, my pain today is about a 5 on a scale of 0 to 10.
Okay, and we have time for this one last question. Do you find patients with both diagnoses, so they have overlapping condition, can they begin to recognize the differences if they're having an RA flare or a lupus flare? Yeah. And what might those differences be for them?
Yeah, that's another good question. So all of these, I didn't put the slide in here, but I often for patients have one of a Venn diagram with overlapping circles, trying to get the idea that this whole family of these autoimmune, what we call autoimmune connective tissue diseases, can overlap. And there certainly are patients who can have both lupus and rheumatoid arthritis. We use some terminology when patients have enough that we could make the diagnosis of two separate diseases. I call that overlap connective tissue disease, as opposed to somebody who might have a positive ANA, that Raynaud's phenomenon,
and maybe some joint pain, but not enough to diagnose rheumatoid. I might call that undifferentiated connective tissue disease. But a term that somebody invented probably back when I was in my training was Rupus, R-H-U-P-U-S, to try to get the idea of an overlap of patients with rheumatoid arthritis and lupus. Now, just to back up, some patients with lupus can have inflammatory arthritis, and it's hard to say, do you call that rheumatoid arthritis? Well, I might if they have rheumatoid factor or CCP antibodies as well as the lupus antibodies. But if they don't have those and they don't have the X-ray features that look like rheumatoid, then one could argue, well, it's just lupus, and this patient with lupus has joint inflammation. And it really gets to be the assessment of what's going on. In any patient with lupus, you've got to ask not only what's going on with the skin, mouth sores, kidney, heart, lungs, but also joints. And so that goes into the question of what to do as far as changing treatment. Patients who have more pure lupus, I tend to not treat with the TNF inhibitors. Some people do it, but there have been cases described of inducing lupus-like syndromes from the TNF inhibitors. But if the patient with lupus has an awful lot of joint inflammation that looks more rheumatoid-like, then I'm a little quicker to use those kind of drugs. Hope that answered it.
Okay, wonderful. I wish we had more time for questions, but I notice it is almost the end of the session here, so I do want to say, on behalf of the Arthritis and the Lupus Foundation, I want to thank Dr. Ytterberg for taking time from his busy schedule to provide us with this informative presentation. Thank you so much, Dr. Ytterberg.
My pleasure.
And I want to thank the Arthritis Foundation Upper Midwest Region for partnering with the Lupus Foundation on this webinar, and also community health charities with whom both the Arthritis Foundation and the Lupus Foundation are member charities. And finally, thank you to everyone for joining us today. I hope that you did enjoy today's webinar. And if we didn't get to your questions, I think we might have missed a couple. Please feel free to forward them. But if you could, please take a few more moments to complete the webinar survey that will pop up on your screen. And again, if you need a certificate of attendance, please email me at ccomo@lupusmn.org. And so thank you again, Dr. Ytterberg, for your time.
Okay.
Thank you. Have a great afternoon, everybody. Bye-bye.
Bye-bye.